Hello, everybody, and welcome to the double episode or two episodes today, second half of VMR today. For those of you that joined, we had a very exciting episode of Neuro VMR with a case by Cashiar and Geraldo and Aaron did a fantastic case breaking down a patient with left-sided weakness. So do listen to that if you didn't join on YouTube. A fantastic. I won't reveal the final diagnosis, but definitely something you probably did not anticipate. And I think Yasmin got the final DX, you were saying. Okay, so today I have Mark joining to co-discuss, and Vinicius, who looks like he's busy at a rotation, is going to present a case. So I really appreciate you taking time off your rotation to present one of your fantastic case. And also we have Patricia and Parisa helping out with teaching points and scribing. And also Deborah will also join in the mix to help out as well. But I want to turn the mic over to Mark and see how things are in his neck of the woods. How's things on the West Coast? I actually came back from the West Coast. I had to go to a wedding. So I drove, I was in Sacramento, down to Monteca, to Stockton, to Fresno, to Bakersfield, and back to Sacramento. So I don't know how many miles I accumulated, but probably passed by you. You're in Stanford, right?
Yeah, Stanford. So
All
like
right.
the South Bay. Yeah, I always me and my wife always say we don't know why we didn't come out here earlier. It's just like beautiful out here. We went on a nice hike last weekend in Marin, which is like north of San Francisco. So yeah, I got a moonlighting shift today. I'm doing the emitting shift at like 1 p.m. Eastern Pacific time. So yeah, I'm on like my off week right now. So kind of just in that diastole after I have like a pretty busy week on service.
Awesome. You just about said 1 p.m. Eastern. I was like,
Not
wait,
used to it. Not used
that
to it.
that's in an hour. I hope you can get to work within the hour. And Parisa, how things? I heard you got something cooking in the lab there in the background.
Yes, I am analyzing some of the plates. We did some experiments. Looking forward for the session and learn from you and Mike.
Awesome, awesome. And Patricia just joined. Patricia, how are you?
Hi, Dr. Ravi. I'm fine. How are you?
Oh, great, thank you. And hopefully, and Deborah's going to help out too, I guess. Doing okay. And welcome everybody. Hopefully, interview season. Everybody's getting interviews, and interview season has started for everybody. It starts for me in 2 weeks. So hopefully, see a lot of you on the interview trail. And good luck to everybody applying this year for Match 2025. And yep. Do we take it away with the first aliquot? Vinicius? Oh, Vinicius, we haven't heard from you. How things there?
Yeah, everything's okay. I'm in my internal rotation right now, so I'm really excited to present the case today. Thank you.
Awesome. Thank you. Yeah, you've been, both you and Cashier have been bringing many, many cases. So really appreciate the effort. And we'll take it away with the first aliquot. Mark, you want to tackle the first part?
Am I a co-host, please?
Oh, okay.
Yeah, sure. Sounds great.
Can I start? Yeah, okay. So for the day one, we have a patient with an initial presentation at the outpatient clinic, a 28-year-old female presents to the clinic with a 4-month history of progressive dysphagia and moderate shortness of breath. That's all for first outline.
Awesome. Thanks, Vinny. So we have a young female here with dysphagia and shortness of breath. I think the first branch point, we talked a lot about this, I think, on previous VMRs, but it's kind of distinguishing oral versus esophageal aphasia. And honestly, I'll back up before that. It's not going to be as relevant probably in this case because this is in the outpatient setting. This is going on for 4 months. But always, like anytime you have a symptom or a lab, think of your no misdiagnoses, right? So for instance, an ischemic stroke in the brainstem can cause dysphagia, usually other neurological signs and symptoms. But if someone has acute onset dysphagia, that would be something to think about, or some sort of like acute esophageal obstruction. But luckily we're in the outpatient setting. It's been going on 4 months, so we have a little bit of a time to think. I think, right off the bat, I just kind of asked very targeted questions, getting at oral versus esophageal dysphagia. So I'll definitely love to hear that from Vinny. whether like, is this dysphagia happening right as the patient is swallowing and they're having like nasal regurgitation, which would be more suggestive of oral pharyngeal dysphagia. I won't go into the DDX yet because I just would want to get that history first. Or commonly, I think almost most of my patients who have esophageal dysphagia, they really will point to this globus sensation. They're like, it gets stuck right here. And I always think that's a really nice history, piece of history to localize to esophageal dysphagia. But usually patients will be like, yeah, after I chew my food and I swallow it, it takes a little bit of time and then it gets stuck right here. And then I kind of hone in on the esophagus. So I'll say it's very, for a 28-year-old, I think most of the patients I see, and maybe this is my bias of being like an inpatient hospitalist, but that have dysphagia are much older. I definitely haven't seen, I think many patients, as 28-year-olds with, severe dysphagia prompting like medical care. And I'm trying to think how to, link the shortness of breath as well. I think I'll be able to have a more refined differential once I know if it's oropharyngeal versus esophageal, because then I can overlap dyspnea and oral pharyngeal dysphagia or dyspnea and esophageal dysphagia. Because, some type 1 thinking you can think of, this patient has esophageal dysphagia and dyspnea, you can think of things like scleroderma. This patient going to have interstitial lung disease from scleroderma, and then also dysphagia from scleroderma as well, or, an idiopathic inflammatory myositis causing lung disease and dysphagia. So that's kind of some of my type 1 thinking. I'm not going to jump, right away, but I think, I would definitely want to hear about those history pieces of oral versus esophageal dysphagia. And then also depending on when the shortness of breath started, could this patient had dysphagia for many, many months and then developed, shortness of breath over the last 2 weeks because they had an aspiration pneumonia or pneumonitis? Probably not if the patient looks pretty well and presenting to outpatient clinic, but, you can definitely have a subacute aspiration pneumonia that turns into like an empyema. I definitely seen empyemas. Patients are usually sick, but kind of just brew over a couple of weeks because like that pleura just encapsulates the empyema. So I think just kind of thinking of complications of dysphagia right now. And then lastly, another kind of, I guess, two more kind of broad dysphagia, dyspnea. You could think, anemia, right? You can think of like causes of dysphagia that can also cause anemia as well. And then also just neuromuscular disease in general, right? Neuromuscular disease can cause diaphragmatic weakness. And then also, depending on where the neuromuscular disease is, it can also affect the esophagus or the oropharynx. So definitely want to hone in on that oral versus esophageal dysphagia history. What do you think, Ravi?
Amazing job, Mark, there. You just kind of took both of these complaints, sort of overlapped, and tried to decipher what could be causing or what could be responsible for both. I'm kind of alarmed at this young person. So you rightly said this patient's coming to the clinic, so it's not something that may be life-threatening, but could progress into a life-threatening disorder. So that the patient coming to the emergency room, you're worried about them being able to protect their airway. But I mean, we do see patients in the clinic that we then have to move to the emergency room for interventions to protect their life. Just the age bothers me. So there are certain conditions you kind of mentioned, the autoimmune phenomena. Maybe you could even bring in some neurological phenomena. 28 years of age, we always talk about, bad genes, bad protoplasm, bad luck, bad drugs, and then bad diseases also. So a couple of them you kind of touched on. But if I'm kind of thinking, while you were talking, I was kind of thinking a pendulum swinging between two different states. One is anatomical disorders. Second is neurological disorders. Third is inflammatory disorders, which probably there's other buckets too, but namely those two or three things. And anatomical wise, dysphagia is near the airway. So there's something that's connecting both. I don't know if it's tissue, if there is inflammation of tissues lining the airway and also the esophagus. I'm not sure, but I like some of the things you pointed to, like chronic aspiration. It could be something that could build. 4 months, maybe inflammation. 4 months, an acute infection, less likely, but something that's sort of waxing and waning, taking some time to develop. But at this point, there's nothing really to latch on to. There are certain hypotheses we have, but rather than just bringing up diseases at this point, I would kind of think about, okay, what kind of major systems could be affected? And that could help to direct us to what kind of testing we want to do as well. Because with this, I think it's hard to like just come up with a diagnosis at this point, but testing will help to further decipher the diagnosis. At this point, there's nothing really that is alarming with this patient, but I think we have the luxury of time to sort of get more aliquots and then think further. Any other thoughts, Mark, before we go back to Vinicius?
No, I think the history. It's a lot of this is going to be in the history, so I'm excited to learn more about that HPI, especially the time course of the oral versus esophageal, and then kind of when the dyspnea started around with this syndrome as well.
All right, perfect. So for just to clarify, after talking a little bit more with the patient, she characterizes a esophageal dysphagia, and now I'll continue. And then for the second aliquot, we start to investigate. You ask for some labs and imaging and arrange a follow-up consultation. But in the meantime, one day after, we start the hospital admission story, and the patient experiences a worsening of shortness of breath and general malaise. She's brought to the hospital by ambulance, presenting to the emergency room with hypertension, hypoxemia, sweating, and cold clammy skin. And despite the absence of apparent tachypnea, she was using accessory muscles to breathe. The decision was made to intubate, though it was a very difficult airway due to a small mouth opening, which required anesthesia intervention. And after some laboratories and clinical evaluation, she was diagnosed with septic shock, started on vasopressors, and initiated on antibiotics with cefepime. Suspecting septic shock of pulmonary origin, the patient was transferred to the ICU. And despite negative tests for infection, antibiotic therapy was escalated to piperacillin, tazobactam, due to refractory shock. And she gradually was successfully weaned off of vasopressors, but it had difficulty being weaned off from medical ventilation and required a tracheostomy. She continued on mechanical ventilation due to a low muscle strength. And during the ICU stay, the patient developed ischemia in the left lower limb, which required an above the knee amputation. So she also had recurrent episodes of syncope and hypertension, with concerns about potential autonomic dysfunction. And eventually the patient stabilized and was transferred to the medical ward. So I can stop here, or should I go to the history of the medical wards that when I was about to see here?
I think we can stop. There's a lot to sort of unpack here, but what a turn of events. Especially we were kind of anticipating at the beginning, we're in the clinic. So now we don't have the luxury of time. We have to implement life-saving measures. So what's interesting here that Vinicius, we kind of talked about the airway. So we have to do RX before DX, right? So save the patient, and then once it's stabilized, we can start thinking about what possibly caused this sequence of events. But what was interesting, you'd mentioned about when going to intubate the patient, there was a narrowed or anatomical abnormality on visualizing the airway. So now there's something we can sort of concentrate on. And if you look at the airway, you know exactly where the airway was narrowed. Was it above the vocal cords, below the vocal cords?
I'm sorry, can you repeat, please?
Oh, sorry, I didn't hear.
No, if you can repeat, what is the question?
The airway narrowing you had mentioned, was that above the vocal cords or below the vocal cords?
Was it above the vocal cords?
Above the vocal cords. Okay.
Yeah, she had like difficulty to open her mouth.
Okay, good. Okay, got it. So then we have to think about what could involve the upper airway above the vocal cord. So there could be a number of different things. Narrowing could be a mucosal issue, submucosal. Could it be external compression? Could be any number of things. So, and then this patient went into septic shock. So we have at least the domain of infection involved with this. So anatomical abnormality, which involves infection / inflammation. Because sepsis can be without infection, it can be inflammatory response as well. So what kind of things are we thinking about? It could be anything that could be involving the pharyngeal, retropharyngeal space, and then also the oral region as well. So any one of those areas could be causing. I didn't hear like tonsils could also be involved too, but when going to intubate, you would have seen these hypertrophic tonsillar abnormalities as well. So I'm just wondering if there is an abscess involved there that's narrowing the airway. Unlikely a tumor at this phase, but tumors can become necrotic and also become infected. And then for the examination, if there were lymph nodes or anything like that, that also could be a clue to an infection originating from the mouth. And what kind of infections could we have? We could have anaerobic infections, gram-positive infections, so anything from staph, strep, nocardia could be involved too, to fungal infections. Fungi do also are harbored in the mouth as well. But at this point, I think definitely imaging will be key to really see the extent of this abnormality. What are you thinking at this point, Mark?
Yeah, this patient got sick really quickly. And Vinny, can I just for the time course, was it like she was doing okay in outpatient, and then like hyperacute, like one day she became dyspneic, hypoxemic, and got like rushed to the hospital? Like, is that how it kind of develops, or?
Yeah, so the thing is that she will already had this progressive symptoms during 4 months,
Yeah.
and when she was evaluating in the patient clinic, and by that moment she was doing okay, but then she afterwards so one day after she just developed a like acute respiratory failure.
Okay, gotcha. And then any more further description of the difficult airway? Was it mainly her small mouth, or was it anything in her upper airway? Like it's not like she had tracheal stenosis or something like that that led to a difficult intubation. It was just all her small oropharynx was the big.
Yeah,
Okay.
definitely just the small mouth.
Okay, gotcha. Yeah, because when I heard difficult, airway, especially in someone that wasn't previously intubated, tracheal stenosis definitely comes to, is something to think about. And again, as someone that has the most common cause of tracheal stenosis is from prior intubations and from traumatic intubations. But if someone has de novo tracheal stenosis, and we've been talking about autoimmune disorders, vasculitis, relapsing polychondritis, all those things come into play, but it sounds like it really was the small mouth. And I'm just going to use one again, because I've seen a case similar to this before of just type 1 thinking, like scleroderma, can cause a small oral aperture and definitely can cause esophageal dysphagia, definitely can cause chronic lung disease as well. But I would say I'll just focus right now just on the hyperacute dyspnea, and or kind of acute on chronic dyspnea, or acute on subacute, and then hypoxemia. I think we probably have a good reason, right? Most common causes of like rapidly progressive hypoxemia in the hospital are usually aspiration pneumonia / pneumonitis, bronchospasm, flash pulmonary edema, pulmonary embolism. Those are kind of the big one, pneumothorax. And I think given this patient's history of dysphagia, it probably was an aspiration pneumonia that led to septic shock. I was interested first in the cold, clammy extremities, because I'm like, oh, is this going to be a non-distributed process? Does the patient have a pulmonary embolism that we're going to need to figure out what the cause was? But it seems like, this patient had septic shock, and then improve with vasopressors and antibiotics. So I'll kind of put that to the side for now, because I think it's a pretty common complication of the dysphagia. But yeah, I'm very interested in, a lot of patients. How long was this patient intubated for? Because they required a tracheostomy. So at least in the U.S., it's common after at least 10 to 14 days being intubated to get a tracheostomy. I'm curious what the practice is where you practice, and how long this patient was intubated for.
Yes, so it was about 10 days. And and definitely the conclusion was that she had an aspiration pneumonia.
Gotcha. Okay. So yeah, I mean, when patients, are on a ventilator for a significant amount of time, they do sometimes get neuromuscular, weakness and critical illness, myopathy, neuropathy that makes it difficult to wean. But it's hard for me to detach the patient's past medical history when we are already talking about neuromuscular diseases, not to think about, could this patient have diaphragmatic weakness from an idiopathic inflammatory myositis that led to the dysphagia, led to lung disease. So I'd definitely be interested in a CK aldolase AST, curious where those muscle enzymes are at, keeping in mind that things like amyotrophic dermatomyositis and some other myositis can have a normal CK. So I've been seeing a few cases of like normal CK causes of inflammatory myositis. I've had a lower threshold to order the myositis panel for sure if the syndrome fits. And then I think we just, we need to evaluate the esophagus, right? I think step one would be getting like a barium esophagram to see if there's really anything structural that that is causing this dysphagia, or if we're getting a strong history, if the esophagram is normal and we're getting a strong history that this patient might have a motility disorder that could link to scleroderma, right? Maybe a esophageal motility study. And then I think this patient really just needs imaging. I'm sure they had imaging in the ICU of their chest, definitely a chest X-ray at a minimum, but most of you guys know I love CT chest, and I think this is a pretty good a case that probably requires a CT chest because I'm starting to get a little bit of a rheumatological ILD esophagus overlap. And I'd be very curious. I think this patient needs a really good skin exam. Most patients with this severe, let's say this patient has scleroderma, or if that's something we're considering, usually if they have severe esophageal involvement, if they have diffuse cutaneous and lung involvement, they'll have some skin involvement, but also they could have crest or scleroderma sign, or what is it? Sign something, essentially scleroderma without skin involvement, which is like 5% of patients. So very curious in a good skin exam, very curious in the muscle enzymes, curious in the esophagram, and the chest imaging will be my kind of next steps.
All right, perfect. So I'll tell the chest CT, and then I'll go to the wards history, right? So the chest CT revealed a consolidation in the right lower lobe with air bronchograms and a hypovascular material in the segmental bronchus, consistent with an infection slash inflammatory process, potentially aspiration pneumonia, and possible interstitial pneumonia of unspecified type. And so these was the DX. And about the third aliquot and the patient now, I'm seeing the patient in the wards that I can talk and understand better on the spectrum. And the patient reports anorexia for the past 5 months, for progressive weakness and dysphagia, and now is tolerating only liquids. She continues to lose weight and reports progressive dyspnea with fatigue and orthopnea, requiring 3 pillows to sleep. She denies fever and night sweats. Review of systems. She reports itching in her hands, difficulty closing her fists, and dry skin, but denies any Raynaud's phenomenon. She also notes mucoid discharge from her urethra, denying dysuria or food odor. Besides, the past medical history is not known for previous comorbidities, not using any kind of medications. Family history, mother has systemic scleroderma. Sexual history denies alcohol and tobacco use, no allergies. Yeah, I think that's good for now.
Yeah.
Yeah, at this point. So what's interesting is with the background that there's no anorexia. Oh, actually, there is anorexia dysphagia. This has been leading up for a while. And I like what Mark had mentioned about the esophagus and possibly having a connective tissue disorder flavor. And I think the scleroderma phenomena is interesting, and imaging definitely will help. You tend to have I think, a dilated esophagus on imaging. And then no hint of myositis, so no pain. Usually with like scleroderma, you might have proximal muscle weakness or myalgia. But CPK, definitely aldolase, like Mark had mentioned, will be very helpful in this case. in addition to imaging, anything else with this that I can think of? I mean, dermatomyositis, polymyositis, if the skin is not involved, definitely polymyositis. And again, CPK may be elevated in this manner. If you think about the esophagus as well, there's two kind of different muscle constitutions that are within the esophagus. So you have skeletal muscle and smooth muscle. So the lower 2/3 are smooth muscle, which will be involved with something like scleroderma here. And I think we lost Vinicius. Okay, he's back. So that can be definitely something that could be involved. But yeah, skin exam, at least if you're thinking about dermatomyositis, you want to at least check. It could be evident on the face with the heliotrope rash, and then looking at the legs for the Holster sign, and all the different kind of other signs that you may get with dermatomyositis. But that if you don't have skin changes, then you may have to think about or swing over to polymyositis. With scleroderma, you may not actually have skin findings. I think that the term was systemic sclerosis scleroderma. Is that okay? Which is the involvement of the internal organs without anything on the surface with scleroderma. But at this point, nothing really to pivot on. We have a number of different hypotheses, but I think more data, especially the exam, will be key at this point. I guess I would take the exam and remove some of these hypotheses. Say we don't have skin findings, or say we do have a skin finding, we can probably pivot towards doing antibody testing for something like dermatomyositis. And then also to see if there's any sort of scleroderma association, then also ordering the antibodies for that. But I think at this point, yeah, I'll swing the mic over to Mark, see what he has to say.
Yeah, really interesting case. And I just want to clarify the CT findings. I think you said non-specific. I wasn't sure if you just meant it was non-specific abnormalities, or was it an NSIP pattern of ILD?
Yeah, there is a possible interstitial pneumonia of an unspecified type, and other findings that is consistent also with aspiration pneumonia.
Gotcha. Yeah, I mean, and if this is a true NSIP pattern, which is kind of, I think of NSIP almost a simple way to think of it is almost like UIP with GGOs. It's ground glass opacities. It's one of the ILD subtypes that causes ground glass opacities. NSIP is the most common form of ILD with scleroderma, so that would fit. The idiopathic inflammatory myositis, especially like dermatomyositis, can cause NSIP as well, but it's equally as likely to cause a UIP pattern as well, and also can cause an organizing pneumonia. So anytime you have like an NSIP, organizing pneumonia, or UIP, this kind of alphabet soup combination, it's definitely something to consider. Dermatomyositis is something to consider. Those are really the top two. There's obviously other diseases that I won't go into right now that causes just ILD in general, but those are the top two that are definitely most likely to cause NSIP. So that's definitely interesting with our pretest probability of these diseases. The thing that's like kind of not sitting with me too well is just how rapidly progressive this is. There's a lot of interest. I'll send it in the Academy chat after. There's a lot of interesting and nice like flow charts of like how scleroderma, whether that be CREST or diffuse cutaneous systemic sclerosis, progresses over time. It's a pretty slowly progressive disease. Obviously, not every disease follows the rules, right? But like usually like ILD will take years to develop in terms of scleroderma. Same thing with pulmonary hypertension with CREST. And if we know that this really disease, and we don't always know exactly when a disease started, but it started a few months ago, then I find that interesting. And I was told by a rheumatologist once in residency that if a patient doesn't have Raynaud's, they essentially have a very low probability of having scleroderma. Again, is not a hard and fast rule, but Vinny, was there any hint that this was going on a year before, or was it very like 4 months ago, like all this kind of started?
No, it was very like 4.5, maybe 5 months ago, but the patient does not has any previous comorbidities or any conditions.
And you said this patient also had orthopnea and PND as well. Did you mention? that?
Yeah. She needed like 3 pillows to sleep and difficulties with that. So
And this
yeah,
was
we're talking for sure.
oh, okay. This was in the outpatient setting or in the hospital?
No, that was in the in previous, So when I talked to her, she revealed that, and what I saw her when after the first like emergency situation, and when I tried to understand better what is going on, she like revealed what is occurring for the past 4 to 5 months. So she revealed the progressive shortness of breath and the orthopnea, all those findings. The
Gotcha.
dysphagia also.
Gotcha. Okay. So it seems like this patient also is endorsing some left heart failure symptoms, right? We know that CREST syndrome can definitely cause pulmonary hypertension, right heart failure, but the orthopnea and PND definitely make me think of left heart failure as well. And diffuse cutaneous systemic sclerosis can definitely cause a restrictive cardiomyopathy, and definitely can affect the heart in many ways. But as we've had on the DDX or orthopnea, which I learned from you all, definitely it expands from heart failure. And we've been mentioning like diaphragmatic weakness, right? When you lay down and your diaphragm's weak, it'll definitely make you feel short of breath because it's just pressing your thorax up. And then, too, I think positional dyspnea also makes me think of like things compressing the trachea or the esophagus too. I don't think we got a hint of either a mass or a lymph node or anything like that on the CT scan, but I definitely seen patients with upper airway issues or mediastinal issues get positional dyspnea as well. But I definitely would love an echo and EKG in this patient to see how their heart is doing. And then, like Ravi said, I'm definitely interested in exam and some basic labs, because also if we're endorsing like this is new onset scleroderma renal crisis usually happens in the first couple of years after diagnosis of scleroderma. So I'm definitely interested in the creatinine. And then, one last thing. I've been just trained to think like that because I saw a few cases in residency, but anytime you have a case of rapidly progressive ILD, always think of MDA5 dermatomyositis, because that's the one that can progress very fast. So, some features maybe we can see on exam if they have of that, but yeah, great case.
So
Good.
I'll go on. Or
Back to you, Vinicius. Go ahead.
Okay. So for the physical examination, I'll ask to Patricia to show a picture. Please, can we do that, Patricia? And meanwhile, I'll say it out loud. So the general examination reveals a thin, pale, hydrated, not cyanotic or icteric, with calcium, lungs, clear breath sounds, no respiratory distress. The physical exam that was really in the board, right? So cardiovascular, the blood pressure was 90/70. And other vitals normal, abdomen normal, extremities no edema, the healing amputation site with dressing of the left leg. The skin examination. So now we have a thickening of the skin on her hands, something that really appears to Gradon papios, and no diffuse thickening of the skin on the chest and or upper limbs or remaining leg. And about his labs, we have a hemoglobin of 10 and a hematocrit of 33, MCV of 97, leukocytes of 12,000, B1 normal, creatinine 0.3, and sodium, potassium normal, CRP of 1.3, ESR of 100, LDH of 500, and a CK of almost 800. I can go to the echo also. So with the echo reveals a mild pericardial effusion inferior to the left ventricle. We also did a cranial CT and angiogram that came back normal. That's all.
Oh, do you want me to tackle? So we're missing some of what I was able to get. We're missing some of the exam. So just from the picture, was there sort of telangiectatic changes? The cheeks kind of stood out to me. The lips, it wasn't. I mean, for an older patient, you had to have a face devoid of wrinkles, but with the face, the younger person, the lips were kind of pursed, so we could say there's possibly xerostomia. And then with the limited size of the mouth there, it's kind of concerning. We're probably thinking about, again, scleroderma. And I think with limited, there may be more skin involvement, but I may have to look at that. But the telangiectasias usually happen with the diffuse variant of scleroderma. The CPK was elevated, 800, I think it was, Vinicius.
Yeah, the CK was 800.
800, so that's definitely elevated. It's not in the range of rhabdomyolysis, but elevated enough that there is muscle involvement. So does this pivot us to consider ordering the antibodies in this case? So I think so, especially with the exam that's showing skin changes, and also with the hands as well. So the hands, you tend to get you do initially get atrophic skin that then becomes more sclerotic over time, and then you may get the sclerodactyl. Although you didn't mention sclerodactyl in the fingers, but the skin findings on the hands, definitely that also is a signal for diffuse, where you get swollen fingers and hands, and then you end up getting the atrophic skin. So definitely I would do antibody testing. It will be, I think we have enough pretest probability for this condition, and we would swing over to at least decipher if this is the cause for this patient's presentation. What also bugged me was the CT findings. So with the lung involvement, there's only the right upper lobe. I don't see signal in the other area. And what is this hypodense material in the segmental bronchus? Maybe it is food particulate matter, but that was kind of concerning. But aspiration pneumonia is usually right lower lobe, because the right bronchus is more, I guess, because of the position, it allows for any aspirated material to then move into the lower portion. I think it's a superior segment of the superior posterior lower lobe on the right side that gets involved, rather than the left, which is more horizontal. The right is more vertical, which allows for the movement of the material down into the lung. So upper lobe, unless the patient is lying, if I'm correct, lying down, that might allow for material to move into that part of the lung. But I would move on to further testing, order the antibodies, and then see what comes back. I think sometimes you even can get an overlap with rheumatoid arthritis, so definitely getting the anti-CCP for this rheumatoid arthritis SCC overlap. Anything else comes to mind, Mark?
Yeah, I think we have a huge pivot point, essentially just like thickened skin, which I learned from Ravi, and then also doing reading after a case of scleroderma that I had in residency, that there is, a differential for, thickened skin. I think I really only knew of scleroderma before like a year ago, but and I actually tweeted about this maybe a month ago. But essentially I'll just kind of say them, is that, first, scleroderma, definitely. There's something called scleromyxedema, morphia, which is essentially just like localized skin scleroderma, eosinophilic fasciitis, and then also nephrogenic systemic fibrosis. And that's really with old MRI contrast. I won't go into the, and sclerodema. Sorry, that was the last one, sclerodema. Those are kind of like the 5 things like on the differential for thickened skin. And again, I won't go into this because I don't think really they're likely. And I think we're just likely dealing with scleroderma here. And yeah, I definitely think that this patient needs rheumatological serologies, especially the scleroderma serologies. There's certain scleroderma serologies that are associated with different features of scleroderma. So, for instance, like SEL70 is highly associated with ILD. RNA polymerase 3 is highly associated with scleroderma renal crisis. And then the centromere is associated with pulmonary hypertension. So it's good to kind of know those associations and know what the patient is at risk for. I see that luckily the patient's creatinine is 0.3. Just looking at the patient's physical exam, though, they look rather cachectic, and I think that Vinny described that. So maybe this creatinine is a underestimation of this patient's true GFR. So, a cystatin C would probably be helpful in this case. However, cystatin C is tricky in a few instances. Inflammation can increase the cystatin C. Steroids can increase the cystatin C. So there's some caveats, and, this patient's ESR is 101, and we're thinking about an autoimmune disease. So maybe I think it's going to be more accurate than the creatinine, but the reason why I'm kind of harping on the creatinine too is because the patient's hemoglobin is 9.9. Now, I would say in any other patient patient's been in the ICU for 2 weeks, I would always do the basic labs, nutritional labs, but this patient's probably has a component of anemia, of inflammation going on, just being sick in the hospital, maybe has some vitamin deficiencies, iron deficiency. So those are easy ones to easy labs to order. But scleroderma renal crisis does cause like a microangiopathic hemolytic anemia. This patient's LDH is 554, so I definitely would get a blood smear and order some hemolysis labs, even though I think it's probably less likely. And then the echo too, I'm glad that it seems like the EF is preserved, which is good. And Vinny, no comment on like RV dysfunction or tricuspid regurg or elevated PASP, suggestive pulmonary hypertension, like anything like that?
No, not significant about the tricuspid wall or any from the right side.
Gotcha. Okay. Because scleroderma can also cause pericardial effusions. It can cause like almost like a serositis, like lupus and rheumatoid arthritis. So I think that I've learned that there's so many overlap syndromes. I do not know even probably 1% of them, but after doing some reading on scleroderma, that case I was talking about, that I think one of the most common addition to RA is ANCA, this ANCA scleroderma overlap. So if you guys read a lot of the up-to-date pages on like new diagnosis of autoimmune disease, at first I was like, why for this disease are we ordering like RF, ANCA, all these? And it just like at the conclusion will be like, there's so many overlaps that essentially we test for almost all the autoimmune diseases when we diagnose a new autoimmune disease. I'm obviously exaggerating, but like you have a very low threshold to order. Like in this case, I would order the myositis panel. Maybe I'm not familiar with like a myositis scleroderma overlap, but I'm sure it's possible. So I definitely would order though. You saw the scleroderma labs, the RF, the ANCA, and the myositis panel for sure.
Yeah, I would add ANA to that. ANA would be elevated in that. Sjogren's, lupus, maybe like you mentioned, lupus could be overlapping as well. What was interesting, like the anti-SEL70, they do tend to develop pulmonary fibrosis. Although, are you getting a sense of pulmonary fibrosis from this CT? I'm just getting the right upper lobe, but it's not bilateral, sort of diffuse process.
I think someone in the chat put at the end of the report, that's why I was commenting on NSIP before. There was like possible interstitial pneumonia of unspecified type. I assume that they might be getting at NSIP based on that, but it seems like there is some sort of interstitial process that maybe is early and not until like end stage, like fibrosis possibly. But yeah, they put that on the end of the report. But
right, and then the other antibody is anti-centromere, which usually is associated with pulmonary hypertension, which could explain the orthopnea and so on. Yeah, definitely interested in the autoimmune workup and spending the $500 high value care if it's necessary or not. But I think we should go ahead with that. Vinicius, back to you.
All right, perfect. So I'll just pass the antibodies in the chat and give me a minute right now. So yeah, so more advanced labs, we have an ANA per titer of 1 over 1,280 with nucleolar patterns, normals C3 and C4. NT-RNP negative, as well as SSA and SSB, and Smith negative, and Square 17 negative, lupus anticoagulant negative, anticardiolipin, both IgM and IgG negative. The antibodies that you guys are looking for, we are so planting into today. So anti-Jo1, anti-centromere, anti-topoisomerase 1, and we also couldn't have the possibility to do a muscle biopsy. That's all. I'll pass it to you guys.
So did we hear that, like, essentially the only antibody that was positive was the ANA? Is that true?
Yeah, the ANA is the only one that is significantly positive.
Do you have the ratio, Vinicius?
Yeah, 1 to 1,000, 212V, 80 over, right?
You want to start with that, Mark?
Yeah. So, we have a positive ANA, which kind of just opens the door. It's almost like an ESR and CRP. It just like opens the lab in a way to like an autoimmune phenomenon, right? We learned yesterday in VMR how common a positive ANA is in the general population that doesn't have autoimmune disease. Scleroderma is one of those. There's like 3 big autoimmune diseases that almost universally have a positive ANA, that being SLE, scleroderma, and mixed connective tissue disease. So we are, like Ravi was saying, like our pretest probability for ANA being positive is pretty high. So this is, doesn't really move us forward too much. All the other antibodies being negative is interesting. I'll keep going back to this case in residency, because I think honestly learning from your patients is so important. I encourage all of you guys to it's so much easier to learn from your patients than just kind of opening up a book and like reading, like a random chapter or something like that. That's also great. But if you can have a patient in mind and have target your reading, I think it sticks so much more. So I learned from that case that actually these scleroderma antibodies are pretty bad. They're only, a lot of them only are positive in like 15 to like 40% of patients. So they're kind of a coin flip, and even less than a coin flip. So I think this makes the diagnosis very challenging. But I still think scleroderma is possible, even though these antibodies are negative. I'm very curious in the muscle biopsy. I'm wondering if there is a scleroderma myositis overlap. And I guess in this case, right, dermatomyositis, we don't really have any prominent skin features, Gottran's, but all the skin findings that Ravi talked about, we don't really have those. So could this be an amyotrophic dermatomyositis scleroderma overlap? Maybe. Could this be polymyositis? I mean, usually that's in elderly folks and is more asymmetric. It's usually actually distal and asymmetric, which is kind of against the rule of myopathies in a way. Or sorry, that's inclusion body. I think I was talking about inclusion body myositis is the one that's more distal predominant in elderly folks. And then could this be polymyositis? That's possible as well. And then, there's always this necrotizing autoimmune myopathy, which we learned, I think VMR last week, can be triggered by statins or other drugs. But yeah, I'm thinking the syndrome fits perfectly for scleroderma. And the labs are negative. In that case, it's either maybe retest the labs, because I've seen cases where, labs become positive, or no lab is perfect. You kind of go with your gut, stick with the syndrome, and say this patient has clinical scleroderma. And then also we're going to see what the muscle biopsy shows. So yeah, room is tricky, Ravi. I wish the lab.
Absolutely. I think I just love from the get-go, you kind of venturing into that domain, but I was kind of cautious. I didn't want to heavily invest, but I'm really interested in. So ANA in itself, a lot of the population is going to have be ANA positive, but does that indicate illness? But this is markedly elevated, 1 to 1,000, although we have to be cautious. The degree of elevation doesn't necessarily correlate with the severity of disease, but if you look at when should we consider ANA to be positive and then use that as a pivot point, 1 to 80, but although some rheumatologists may say 1 to 320, this is 1 to 1,000. Okay. The next branch point, like you had mentioned, what kind of things should we think about? So lupus, idiopathic inflammatory myositis. We talked about Sjogren's, we talked about scleroderma, and then mixed connective tissue disease. And you kind of hinted about maybe scleroderma / rheumatoid, scleroderma / myositis, dermatomyositis, polymyositis. Although we're not getting from that picture that Vinicius has put on, it definitely looked like, you know, the lips there, maybe some, if I'm correct, some telangiectasia, something was wrong, was going on with the cheeks there. And then also the hands. And if you look at the hands, I think we still have to stick and not deviate away from an initial hypothesis or our top leading differential, which was scleroderma. And I think that pretty much explains everything. And I think, like you said, the patient is on a journey through this condition. Maybe it's early for the SCL and the topoisomerase and everything to be positive. So it may take time to manifest. So maybe repeating. We've had many tests where it's done and it's a false negative. We may just have to repeat. Kitten presented a case, I'm thinking it was rheumatoid, where the labs, you know, everything was looking like that condition, and then only repeated testing confirmed the leading hypothesis. So I think you're right. I would I definitely would pull in a specialist who has more experience with this kind of presentation. Number two, then repeat testing, and then a muscle biopsy in this case. I don't have enough experience to say that. Is there a particular pathological configuration on a muscle biopsy that can yield a diagnosis? I'm not sure at this point. But yeah, I would definitely repeat and then also communicate with the rheumatologist, and then also look on a reference. So that would be your practice-based learning, which is what we teach in residency. So do you utilize the resources, the literature to further read and apply to your patient, studies, and so on? For this patient, definitely a quick look at whatever reference you usually use to see if there's anything else that we can use to decipher the diagnosis. Anything else, Mark, before we swing the mic back to Vinicius?
Yeah, the one thing I just want to say in a case like this too, when the, you know, again, when the labs are negative and the syndrome fits so well, I think that I'm glad that we have the thickened skin as, like, for me, that was just like a huge pivot point, because the differential is so short, and the other differential diagnosis for thickened skin just seems so less likely, because I'm just thinking, like, what if we took out the thickened skin, right? And this patient just has esophageal dysphagia, NSIP, a positive ANA. Like, this would fit pretty well for an idiopathic inflammatory myositis without skin involvement. And then I think the muscle biopsy, I don't know if like an MRI of the thigh was obtained, because usually, at least at the centers that I've worked at, like, we'll do like an MRI of the thigh first to see if that there's active inflammation, and then kind of target the muscle biopsy at that site of active inflammation. But if you take out the thickened skin, then I think like an MRI of the thigh with a muscle biopsy could definitely help us. I know some causes of IIM, like, are more likely to be more like show more specific findings on biopsy than others. But yeah, honestly, if that patient didn't have thickened skin, I think it becomes a lot more difficult. But yeah, very curious.
Oh, perfect. I love the discussion because I just said like one word, dysphagia, and we already got to scleroderma. And so I'll review the diagnosis by problems. So the patient started initially with a septic shock of pulmonary origin, and secondarily to acute hypoxemic respiratory failure, need to intubation, and afterwards tracheostomy. But the main diagnosis of our case is what is called an overlap syndrome. I wasn't familiarized with that before. And so we have a mixture of what they call it sclerodermatomyositis. And so we have both features of dermatomyositis and scleroderma. And the patient like had pelvic and muscle weakness and cervical muscle weakness and elevated CK, rectum papios, some interstitial pneumonia. She also had microstonia and distal skin thickening and phalangiectations. And yeah, despite all the antibodies came back negative, we don't have it at our service, and the anti-scler like 100, the anti-Q, or more specific antibodies. And the thing is that our patient was diagnosed by uh, a a conjunction of symptoms and signals. So basically the American College of Rheumatology created a criteria. So we based the diagnosis on that. And we also had other things that can help us to the diagnosis. And we have the Bohan and Peter classification criteria to diagnose dermatomyositis. So despite all the majority of the laboratory came back negative, we based it and what was it, the diagnosis on those criteria. And yeah, so the thing that I learned from most by this patient is about these kind of criteria and how to manage the both diseases. I wasn't aware about the clinical spectrum of these overlapping syndromes. So that's all. Thank you guys for giving the opportunity to share this.
Fantastic case for Nisi. Very, very interesting. Definitely, I would have to read this overlap. Just wondering, was an anti-U1 RMP done for this patient?
Anti-U1 RP can come back negative.
Came out negative. Okay. So yeah, like dermatomyositis is not part of that mixed connective tissue disease, but autoimmune myositis and scleroderma, as Mark had mentioned, is part of that phenomena. But definitely a lot to learn here, especially when you take both dermatomyositis and also scleroderma. But I really appreciate you bringing this case, and fantastic case, and especially the photograph that you brought as well. So appreciate the effort. Mark, any final thoughts?
No, awesome case. Just like endless learning. Like any rheumatological disease can overlap with another. And I'm just wondering in my head too, when I was talking about the timeline of progression of like typical scleroderma, that's usually pretty slowly progressive. Could have been the myositis that made it more rapidly progressive. It's just like a thought I had. But yeah, no, awesome. Thanks for bringing this case.
Yeah, so thank you guys, and I was just amazed at how you guys like keeping straight to the main possibility, and just from one to two words, and you guys are just pointing to in the right direction and talking about scleroderma all the time. So yeah, amazing.
Oh, and we have teaching point. Parisa, would you like to take it away? Thank you.
Yeah, thank you everyone. Winnie, it was amazing and it was a really rich discussion. I learned a lot. We started with a case and we discussed that outpatient setting usually allows us more detailed evaluation and the lower probability of encountering acute life-threatening conditions. We classified dysphagia to oral dysphagia, that the issues are at the initiating of swallowing, leading to nasal regurgitation, versus esophageal dysphagia, which are characterized by global sensation, indicating potential problems in the lower part of the swallowing mechanism. We also characterize dysphagia in the other type of the etiologies, anatomical issue versus neurological disorder and inflammatory causes. We talk about diagnostic tools we are having to differentiate all of those. We could use esophagogram, we could use esophageal motility study, chest CT might helping us. We need to do the thorough skin examination for finding any sign of scleroderma or dermatomyositis. We could get muscle and enzyme tests, including CPK, aldolase, or other antibodies for dermatomyositis or polymyositis would be helping us. We talk about a specific condition and their implications, including dysphagia might be coupled with respiratory distress, and these are suggesting complication like Aspiration pneumonia, we also need to keep in our mind pulmonary embolism. We talk about that tracheal stenosis could be a result of the prior intubation versus de novo stenosis like vasculitis. We talk about NSIP patterns in ILD, which is UIP plus GGO opacities that are most common cause of most common presentation of the ILD in scleroderma. We also talked that most common presentation of the lung involvement in dermatomyositis are NSIP plus organizing pneumonia. We mentioned that the absence of the Raynaud phenomenon significantly lowers the likelihood of having a scleroderma. We discussed that how CREST syndrome can lead to pulmonary hypertension and right heart failure, and the symptoms could be present with orthopnea, and the diagnostic approach like EKG and echocardiogram should be in because we need to rule out the cardiomyopathies in this because of the systemic sclerosis that happening in this condition. We emphasize that rapidly progressive ILD should always raise the suspicion of MDA5 associated dermatomyositis. We talk about physical manifestation of the scleroderma like telangiectasis and also swollen hands and fingers. We talked that aspiration pneumonia usually affecting the superior lobe because of the anatomical position of the bronchus. We talk about the skin condition and differential diagnosis in that when we are having thickened skin, we need to think, and it's not just exclusive to scleroderma. There are other conditions which are presenting with thickened skin like eosinophilic fasciitis and nephrogenic systemic fibrosis. We also talk about different kinds of antibodies could be positive in this setting, like anti-RNA polymerase, which is specific for scleroderma, Raynaud crisis, and anticentromere, which is more probable in pulmonary hypertension. Scleroderma, we also talked that scleroderma could be more slowly progressive, but when some other condition like myositis will be added to the picture, the whole illness script and the situation of the patient could be more progressive rapidly. Thank you so much, everyone.
Thank you, Parisa. That was phenomenal. You called all the salient features of this case and teaching points that markedly told us about from this case. Great thought at the beginning, Mark, for scleroderma. Absolutely fabulous. Any closing remarks, Mark?
No, that was a lot. That was a lot of fun. Thanks, Vinny. Thanks, Parisa.
All
Thanks,
right.
Ravi.
Thank you, everybody. Take care. Bye.